Today's episode is brought to you by the Hippocratic Collective. Check out our shows and join the conversation at thehippocratic-collective.com. Hello, I'm Joan. I'm a Canadian family physician who also works as a restorative medical educator, facilitator, and coach. I create spaces that rehumanize the work of healthcare. I'm creating this podcast to remind myself, as well as anyone else working in a helping profession, that when you are working and caring for your human patients, you are the other human in the room. Before we dive into this week's episode, a quick note for all the healthcare humans out there. If you're doing everything right and still feel yourself exhausted, skipping meals, pushing through headaches, or always feeling behind, this might be for you. I'm hosting a weekly webinar throughout the month of June called Creating Space, Building Your Workday Around Your Body's Capacity. We'll explore the hidden ways we've been taught to ignore our bodies in healthcare and how you can start reshaping your workday to actually fit your real capacity instead of trying to meet all the absurd, inhuman expectations of the system. You'll walk away with a simple, practical framework and real-life examples from clinicians who've made it work. I'll also share more about my Creating Space course and retreat, where you can take this work deeper in real time with me. There are 4 dates to choose from, so go to joanchanmd.com/webinar to sign up for the one that works best for your schedule. Hope to see you there. Hello there, healthcare humans. Thank you so much for coming back for another episode of The Other Human in the Room. I have been so excited to spend some time with this particular healthcare human. Every time I have shared space, whether it's been virtual space or real space, I am soothed and calmed by this amazing person's presence. I'm inspired by all the things that she's doing. I've been watching her journey via LinkedIn as she travels the world. And the main reason I invited her on was to talk about all those travels. But before we dig into it, Tara, would you like to introduce yourself to everybody?
Wow, that was like a very flattering introduction, Joan.
Truthful.
And I'm delighted to be on the podcast because I will say I've always taken inspiration and positivity when I've been in the room with you. So yeah, I'm Tara Kiran. I'm a family physician and also a research scientist. I work at St. Michael's Hospital at Unity Health Toronto, and I also have a role in our Department of Family and Community Medicine at the University of Toronto as our Vice Chair for Quality and Innovation, where I hold the Fidani Chair of Improvement and Innovation. As you can tell, I have a lot of titles. I also am cross-appointed at ICES and other places. But all this to say is I'm passionate about trying to improve the primary care system. I work clinically. I've done a lot of work to try and improve practice through quality improvement, and have also done a lot of work to evaluate how health reforms worked out. I will say though, in the last few years, I've become a lot more passionate about trying to engage patients in the public to understand their perspectives about primary care and their priorities for it. And so in 2022, I launched Our Care, which was really the largest ever national engagement of patients in the public about the future of primary care in Canada. And it's really helped shift my own thinking about where it is that we need to go and what the priorities should be. And then I will say this in the prelude to our conversation, that was a lot of work for me doing Our Care. It was super fun and really interesting and meaningful. I think doing that together with doing that right after the pandemic, I was really tired and I ended up taking a 1-year academic leave, which was really wonderful for me. It was also an opportunity to explore new things. And so that's partly how I started to explore or lean into further exploring, I would say, other healthcare systems in different countries and places in the world.
So are you done your academic leave now? Are you back to it?
I
Oh
am.
my
Yeah, I've
gosh.
been back in the clinic for a month or so. Yeah, so
Wow.
different pace.
Yeah, uh-huh. So that's
And back at my university job. So
right. So
I
that was
took a
like
break
which
from
part?
2 of my 3 jobs.
Okay.
Yeah.
So you
hmm
ceased seeing patients for a year and
Hmm.
also stopped like academic teaching or
My academic role,
oversight. Yeah.
yeah, which is more like an administrative
Yeah.
role, and then continued with the research at the pace that I wanted to and with some freedom.
That's
Yeah.
okay. I would love to hear what helped you make that decision.
Hmm.
Because I think, I suppose in the academia world, it's more of a known phenomenon to take a sabbatical, but I would love for such ideas to spread across perhaps all of
Hmm.
healthcare and the world, but we'll start with
Hmm.
healthcare. Like, what if it became somewhat of a norm and somewhat supported and encouraged for
Hmm.
many physicians and other folks in healthcare to be able to plan and take a sabbatical? Like, taking time away from something can help you really cherish it. So I'd love to hear how that decision was made for you.
Yeah, maybe before I get even to how that decision was made, I'll just say that I do listen to the Happiness Lab, a podcast by Laurie Santos, and she actually had a whole episode on this very topic where she interviewed someone whose whole research, I think, is related to people taking a sabbatical. And so I think, it's if you're interested in that concept, it's worth listening to.
Yes.
And it's this idea of, can you take a sabbatical in any job, and what are the benefits for the person, but maybe also the company and things like that. I will say for myself, it was a wonderful year. It is something that I had wanted to do for a while. So I have three children, and each time I did take maternity leave. The first time, actually, I didn't take too long a maternity leave, only 5.5 months, and then the other two I took a year. And they were the last two in particular were important times. Like, they were busy, but they were also times where I really was immersed in my family life. And then I think 3 years after my third maternity leave, I was like, okay, I'm going to take a bit of a break from practice for like 2 or 3 months. So I just took, like, I had a locum for 2 or 3 months, and that was like really great again. And so I think because I had done that kind of thing, I think I knew the value of being of having a break, actually. And also this idea for me of balancing work and life, that sometimes it's hard to do that on a day-to-day basis, but I once read about doing that over the course of a lifetime. And so if you think about it over a few years or a decade, then, part of taking that academic leave for me was having that balance in my life, for a portion of it, and in fact, balancing other things beside work for that portion of it. I'd also, at the time that I took it was more than 5 years into my tenure chair. So it was like and I had been doing all this stuff, and had been feeling, like everything was a lot. And I also, my kids were at a certain age. Like, my daughter is in her last year of high school, my oldest. And so it was just, there was a lot of things in terms of timing that I knew that I had wanted to do this. And so I had been planning for it for a while. And I would highly recommend it to everyone, if you can make it work financially.
Yeah. And though everyone's finances are different, perhaps if you have it on your vision board and on with enough foresight, you can sort it out, right? Like, sometimes I think if we just think day to day, you're like, I could never, because you kind of are just looking at the now. But what if you make that a part of your
Hmm.
plan? Like, it depends on your circumstance, but I would imagine I'm like definitely like, okay, this needs to happen for me at some point.
Well, I also think, there is a lot of discussion, of course, about burnout in family medicine and people leaving the profession. And I often feel like I wish everyone would be able to just take a break, because I feel like that would be just so much better for everyone, the system, for the person, because you can take a break, you can feel a bit refreshed, you can have perspective, do some of the things maybe that were on your backlog. Like, frankly, like, some of the things I did were like taking my kids to the doctor and the dentist and the eye doctor,
Yeah.
like all those things, right? But then, you can come back, hopefully, with a different perspective, and or feeling refreshed, or being more clear about what it is that you want.
Oh my gosh, like, um I don't know who we have to talk to, but like literally, this is something. I mean, you'd have to build up the funds or find the way to make it
Hmm.
happen. But like, if
Hmm.
you're like, gosh, so right now there's all the headlines like family doctor another one closes their practice, da da da.
Hmm.
What if it's like there actually were funds and it was like a sabbatical program, and so you can take your pause. I'm just saying, I would vote for that person or that program.
Well, the teachers do it by saving up, right? Like they spread their income of 3 years over four,
Right.
for example, or 4 years over five in order to do that. And so it's kind of like it's not that they're getting paid more like to not work. It's just that they're spreading out their income in a way that forces the savings. That's my understanding of it. I don't.
No, I've heard
Uh,
that. Yeah. And so then the thing would be, so maybe it's some piece of the system pays for your locum. Because then that would make it more equivalent. Listen, I'm just spitballing here. I'm not no commitments needed, but I
we're
love a practical
redesigning the healthcare
solution.
system right here. Yeah.
I love the practical chunks. That's what I've learned. Like the big system stuff, sometimes it hurts my brain too much. But when we start talking practical chunks, like that's why,
But I guess what I'm saying is I think everybody has some probably agency over
yes,
this.
do it for
Um,
yourself.
yeah, so I mean, again, I recognize not everyone has the same agency, but I think many would have some agency.
A lot of it is like you don't even think it's a
And
possibility. You think that
yeah,
it's,
I will
yeah,
say though, I was privileged because I do have a chair that paid me some research funds,
right.
so I do want to acknowledge that.
Yeah, that's a good point. Well, I love it though. That's so, and I'm definitely gonna look up that podcast episode. That sounds good. Okay, so then you're on your sabbatical. And so my understanding is that one of the things you did on your sabbatical is you went to different countries. So tell me about that whole journey and what brought it on and what you were looking for there.
Yeah, so one thing that I've been studying is, of course, the family doctor shortage, the primary care shortage in Canada. We have more than 6.5 million people who don't have access to primary care per, our care survey that we did back in 2022. And, at the same time as I'm thinking about this problem in Canada, I was reflecting on the fact that there are other countries out there where this is not a problem. And what is it that they are doing differently that we could potentially learn from? And so I worked with a wonderful medical student, Heba Shahed, as well as Rick Glazer, one of my close colleagues, and several other people to really look at this problem in an academic lens. And we actually published a paper in the Canadian Medical Association, I think back in December of 2023, I think it was, where we compared Canada to 9 OECD countries where 95% or more people have access to primary care. And we were able to pull out some, lessons, some themes from that work. A lot of that was based on things we read, literature, stats that we gathered, also some interviews that we did by Zoom. And I think we have some great insights in that paper. But I will say that work kind of just whet my appetite for really understanding more deeply what are things like in these other countries and what are the lessons that we can bring back, because it really did feel like we just scratched the surface. We did a deeper dive on 4 of the 9 countries, but even that deeper dive, like it was, maybe a couple of hours of conversation at most with some key experts. And so I had this opportunity with the academic leave, and I wanted to use it to do something different that I wouldn't be able to do on my normal kind of pace potentially. And so I also love traveling. And my family, I have my 3 kids, like they didn't want to like come with me to places. So I was like, okay, maybe I'll like figure out if I can just go myself for short stints. And actually, the way the first one happened is I was at a conference in the UK that had been planned right at the start of my sabbatical. And at this conference, it's the BMJ Quality and Safety Conference in Europe, and it was in London. And actually, I happened to be at one of they have these experience days. So we actually were at the Bromley Balboa Center, where they really the home of social prescribing in the UK, which was really interesting. But at this session, there were actually 2 people from Denmark that I met. And I was like, oh, like I've been, that's one of the countries that I've been wanting to go. I have this sabbatical. And like one of them was a family doctor. And he was like, yeah, you should just like email me. I can help set you up. And so like, and then the other person was from this organization called Healthcare Denmark. And it's actually an organization that they have in Denmark where they are, it's like an ambassador type of organization where they are sharing with other countries, places in the world, about what is great about their healthcare system, and learning from others as well. But it's a whole organization actually that they have to do this, to export their what they do, from a healthcare perspective. And so this person also was like, yeah, you can contact me. And then I ended up also contacting the Danish embassy here in Toronto, and they have a health person within the embassy actually, who again is there to help make these kinds of connections. And so in the end, I actually organized this trip in, I'd say, less than 6 weeks, because people were so generous, and the Danes are so organized when it comes to this, and things also just fell into place. And I had a fantastic like 9-day tour, primary care tour. Anyway, I could tell you more about that, but that's how that one came to be, and it came to be like a template for a couple of other ones that I was able to do later on.
Cool. Where, like, briefly, what were the other countries you ended up going to?
So in December, I went to the Netherlands, and then more recently in February, I was in Spain.
Spain. Cool. So, yeah, I would love to hear some of the points, like even comparing, contrasting each of the different systems with each other, as well as with us here in Canada. And obviously, you could write papers or books about everything you found, but like,
Yeah.
especially things that really surprised you, maybe like were there features that you really wouldn't have predicted would work well or that you hadn't heard of before?
I mean, I think all three systems. So I will just start by saying that it is important to acknowledge contextual differences. So, I mean, these are Netherlands and the Netherlands and Denmark are, of course, smaller countries. All three of them have smaller geographies. They do actually all Denmark and the Netherlands in particular have a higher percentage of spending on healthcare that is public, like within the public system versus private. They all have higher taxes to a GDP ratio than we do, and Denmark and the Netherlands especially have more social equality. Um, they 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 do have less ethnic diversity, and they are, I think I mentioned smaller geography, but they're also not beside the US, which I think really does change kind of out. So there's a lot of contextual differences that we always have to take into account. But one thing that I really struck me about all three systems was just how patient oriented they were, how customer oriented really they were. In every way that they ran, it was really putting the patient and customer lens at the center of what they were doing. I think Denmark, there's some wonderful examples of that that also speak to the transparency that's kind of part of the system. So, in Denmark, in Denmark, they pay a lot of taxes, but, I'm told that because they pay a lot of taxes, they expect really good public services. And the government goal is that every person in Denmark not just have a family doctor or what they would call a GP, but have a choice of a GP. So that's the government's goal. And so they have actually a website where, there are actually these websites where you log in as a citizen, and you're able to do lots of different kinds of tasks within this website. But one of the things you can do is like find a doctor, and the doctors, you can search in your area by postal code or whatever, who is accepting new patients. And they literally want, if you go onto that website, that there are at least 2 doctors that you will find that are accepting new patients and that you can choose from them. And I will say that it's very fair and transparent, in that, how sometimes here, or I'd say a lot of the times, There might be a doctor who's like their practice is closed officially, but then they're still like taking on friends and family of existing patients, or maybe they do a colleague a favor, all these things. In Denmark, it's like when I mentioned that kind of thing, they were like, no, it's like either you're open or you're closed. It's a very kind of fair and transparent process around that, but also very kind of customer oriented in terms of what the goal is. One of the things that I found, like say they do have wonderful information systems in particular in Denmark, it really stands out. And so we can talk more about that too. But I think one of the things that I was struck by in Denmark was the way they do specialist referrals, which I guess, again, I think really illustrates the patient-centered lens and this and the transparency. So here, referrals, as you know, Joan, is like a mess
Yeah.
for family doctors. It's like it's so awful to, have to on a daily basis navigate finding care for your patients. And what we've talked about a lot is what if we move to a centralized referral and triage system so that, at least if we wanted to, let's say, refer someone to a cardiologist, we'd be able to just use one form and then the cardiologists can figure out amongst themselves, like, who should see this person. So in Denmark, they actually don't do that. What they do is they have a public-facing website with every specialist there in a directory that's searchable by, of course, location.
Come on.
It has their hours, location, the accessibility of the office, and the wait time for that specialist. And the family doctor would fill out a referral, and it would kind of go to this like centralized type of database that any specialist could pull it from. But it's the patient would go to this website, find the specialist they want to see, and then book the appointment with that specialist.
Brilliant.
And so it's
Oh my
really
gosh.
putting it into the hands of the patient in a way that makes so much sense. I mean, it's not this back and forth where somebody else has picked a time, somebody else has maybe picked a specialist. The patient has agency. And of course, if the patient can't do it, the family doctor's office might help. But it's just it's an example of like a very transparent, patient-centered design. I should also say one thing I forgot to mention in terms of context. The other important context for all of these countries is there are probably about 1.6 to 1.8 times as many doctors per capita in these countries, which is a really big advantage for them. So they're all kind of facing some of the same issues we are: aging populations, more medical complexity, a workforce that, has different interests than maybe they did 30 years ago and things like that. But they are really being proactive about thinking, okay, we need to invest in primary care. We need to do something now before things have gotten to a crisis stage. And they are in a better place to be able to deal with that, partly because they have more doctors per capita, not more GPs or family doctors per capita, but overall the doctors per capita.
Yeah. And that's so major, right? Because, of course, hearing, and this is not to like, we're not here dragging Canada either, but just like recognizing our struggles are, like you say, there's different contexts, there's something unique, but I love hearing about functional systems. It's soothing to me. It's nice to know it's
Yeah,
possible.
it really is. And so it was like wonderful to actually experience this that was like things that were so logical. And I was really excited to bring it back. Like when I heard about this referral system, I was just like, I think I even wrote in my post,
Yes.
like, I feel like I'm gonna cry because it's so logical. Like,
Yeah,
why
everyone
don't we
gets their
have
piece of
that?
it. In some ways, it's like, the more chaotic version, but we already do it for other things. Like we give our patient a prescription and then they can take it to any pharmacy. Obviously, this is different. It's a referral, but it's so interesting where it's like we all we are in this weird triangular relationship with our patient and the specialist where we're doing it on their
Mm,
behalf. And then sometimes they're like, actually, I want to see this other person. And then physicians can feel frustrated. It's more work for me. Why is it more work for us at all? Like in this system, they can just choose
yeah,
from the menu.
that's right. And it's a transparent menu and a
Cool.
comprehensive one.
Yeah.
And so I think that's important too. Like they have really good data and, people are held accountable. I will say that, if you're a family doctor, the way it works there, it's quite different. So, they have a contract, the GPs in general, and you can only, if you they kind of regulate whether a GP can open a practice or not. So you kind of have to apply to get the sort of license number. So it's not you're licensed as a doctor, but this is to actually set up a practice. So you have to apply to the region to say, okay, I want to set up a practice, and then you would be authorized to set up a practice if there was actually deemed to be a need. And then doing that actually comes with some obligations. So, so the practices are owned by GPs, but some of the obligations would be that, you have to provide care, be open 8 to 4, Monday to Friday. You have to see patients who are sick on the same day. You have to see other patients within 5 days. You have to participate in an after hours rota, and you have to care for 1,600 patients. And so it's a really, those are really it. Like, it's sort of what I would say are minimum specifications. Like, they're pretty basic, but they're clear. And just to say, it doesn't mean that the GP themselves has to be in the clinic Monday to Friday, 8 to 4, because they can hire a locum to be there 2 days a week so that they can have 2 days a week off. But it means the practice has to be open during those times, and the patients have to be served during those times. And so there is this transparent accountability for everybody in the system. So similarly, like this, all the GPs are on that website. Everybody knows who's open, who's closed, where they are. All the specialists are up on that website. Everybody knows who they are, their wait times, open and closed. And so I think there is more transparency and accountability to the patient so that all patients kind of know what they can expect, and there's clarity about how the system should work.
Yeah, that's so interesting. And
And I will say one other interesting
tell
point,
me,
Karen, is that the GPs there actually make more than specialists, the GP
I was literally
owners.
going to ask about money, just of like, wait, okay, but more than the specialist, tell me everything. What do you mean?
Yeah, so it's interesting. Like, I think that they also have equivalent training lengths in Denmark. So to be a GP, you train for, I think it's like five, I'm going to get this a little bit wrong, maybe it's around 5 years or 4.5 years, and it's about 5 years for specialists. I think it's the reason it's different is that everybody does a like 6 month difference. Everybody does a 6 month, either 6 months to 12 month. I'm getting my details wrong here, but somewhere between 6 to 12 month rotation as a resident, after medical school and before the specialization in primary care or in family medicine. So everybody's in a GP office for a minimum amount of time. And then if you want to specialize to be a GP, then you would, do an extra 4 years or something like that. And then if you want to specialize to be another kind of specialty, you might do like 4.5. So it's very similar lengths of training. And everybody has experience in a GP office. And then, some of the leaders I spoke with there, they postulated that some of the reason the GP incomes rose to be more commensurate and then higher than specialists was when this length of training actually became more commensurate. And so slowly the GP incomes increased. I will say, though, that GPs are very respected in Denmark as well. I've been told that 90% of health system contacts in Denmark are with a GP. So they really look after a lot of things, both in the clinic during the day, but also through their after hours contributions. So, yeah, it's all of those things together, I think, explain maybe a bit why the GP is paid. And just to be clear, it's the GP owners who are making more on average than specialists. So not like the locum, but the GP owners. And I think that's such a wonderful thing. Like, it would be great.
Yeah.
Imagine if that was the
Oh
case
my
here,
gosh.
and how that might change what medical students chose, what residents choose to do, even if they train in family medicine. Because I do think money does drive behavior, whether we want to admit it or not.
Oh, I actually, so I'm faculty at McMaster, and yesterday I gave a talk to like the graduating R2s about like running a medical business. And one thing I decided to do was actually share some of my real numbers of like, this is how much revenue I earned from OHIP in a certain year. And this is how much I took home after taxes, after overhead. And I felt a little, I was like, this feels vulnerable, but I've literally never heard anyone do this. And like, how can you know unless someone shows you the actual numbers? So I just showed mine. And it was interesting after, I asked for like takeaways, and one person was like, taxes suck. And then like someone else after like came up to me and was like, overhead is terrible. And I mean, like part of it is a mindset thing. Like perhaps we could all from the start and onwards really kind of find a way to encourage and foster a business focused mindset, not in a way of like money hungry, whatever, but being like, hey, here's like the cool parts about being a leader in owning your own business, right? But like have that being a really big piece of the training so people will understand that money in doesn't equal money in your pocket, you know. But also, yes, so like say there was more money in at the top, then obviously you would get more money at the bottom. And so it's just interesting to think that like, right, if it was taken into account more so, first of all, just in balance with the other specialists, but also the fact that primary care, especially if you're doing outpatient primary care, the amount you're getting from OHIP is very much not your take home pay. It sounds like that would be somewhat factored into what's happening in Denmark in the sense like, oh yeah, so we're the owner of the clinic, but obviously then we're maybe hiring out locums, or are they employing people themselves and all of that? Like,
They are.
yeah,
So if they're the owner, they're employing their staff. And I think it's only taken, and they pay taxes and all
yeah,
the same things here, and they would have a lot of overhead because they're paying a lot of
right.
staff to look after a roster of 1,600 and ensure same day access, right? Like that's not easy. Um, but I think I get the sense in Denmark, and I can actually speak a little bit more in the Netherlands around this. But I think there's like and more maybe of a calculation of like, well, this is what the target income would be, and this is what the standard expenses would be.
Yes.
And so, you need to bring in a certain amount in order to get your target income after expenses. And in the Netherlands, it's interesting. They don't actually negotiate the fee schedule. From my understanding, it's actually there's an agency that does like audits of family practices or GP practices to understand what the expenses are. And like they update that. And I think that information is actually all public, like on a website. And the idea is that the schedule should change to accommodate whatever changes in expenses might be, but still targeting a certain income for a GP on average. And then, of course, your income as a GP, there's still a lot of variability because you can choose to roster more or less people. In particular, I think that that is one of the about 70% of the income in the Netherlands for a GP is capitation, but in about 30% is fee for service. So you can obviously increase your income by rostering more patients in particular, or of course seeing more volume in a day. So people still have a lot of variation in income, but there is that calculation, I guess, of what the expected expenses might be and what the billing fee codes need to be in order to attain a certain income
Mm.
for physicians.
That's just lovely. Again, I mean, in some ways, it makes business sense for everyone, right? Like, it makes sense that you would look at the individuals providing the service and fund them in a way that empowers them to continue to provide the service. And so one
Yeah.
part of that would be looking at the cost or the expenses that it takes. It seems basic. I'm just like,
It's very logical, isn't it, Joan?
I'm like having emotions.
Is that what you're saying? That it's
It
like very
seems like
logical?
actually
Yeah.
just basic math, actually.
Yeah, yeah,
Oh
yeah.
dear. And actually in Denmark, is it also capitation and fee for service
It's
blend or
both.
okay?
Yeah,
Yeah,
exactly.
neat.
I'd have to kind of look up like again what the split is, but it's a similar type of split where I think it's enough capitation that there is some incentive around roster, but there is also enough actually fee for service that people are motivated to see patients in person.
That's so interesting. So what are that is all so fascinating. Um, other features, maybe, and then, yeah, Netherlands or Spain in comparison to what you found in Denmark?
Hmm. Yeah, I mean, maybe what I'll do is I'll just highlight some of the parts that are really fun and unique in the different countries. So in the Netherlands, it's also a GP owner model, and they don't do quite as well financially as compared to specialists as they do in Denmark, but it's still a respected profession. I think what was interesting about both of the models is that there was also a lot of similar types of delegation in the sense that, and the same thing actually in Spain too, in terms of the role of the nurse. So the role of the nurse in all three countries was is really to do a lot of the stable chronic condition management, and also depending on the country, also support acute care. In the Netherlands, they actually have two kind of designated roles for nurse. They call one of them like a somatic nurse, and that is a person who does the chronic conditions. And so, like things like diabetes, high blood pressure, other cardiovascular diseases, asthma, COPD, anything stable, they'll see them. And importantly, it's different than I think a lot of the teams here, where sometimes a nurse might see a patient and then the doctor would see them afterwards. This is like, let's say a diabetes patient has 4 visits a year standardly. 3 of them would be with the nurse and one might be with the doctor. So it's not a duplicative care. It's really the delegation to the nurse. And one of the things I loved in the Netherlands is they have this whole the Dutch College of GPs, where is a organization, a member-based organization that actually creates guidelines for GPs by GPs. And they are the basis for a lot of things in the Netherlands, including, the work that the nurse might do in the practice around chronic condition management. It's based on the guidelines from this college that, there is integrated stuff in the electronic medical record to support the nurse to actually, do the things that are in the guidelines. Or, if it was me, I would still want that checklist in, an electronic medical record to remind me. But it was interesting in all three countries to see the nurse really be an autonomous provider within the team and take that work away from the doctor. And then I said in the Netherlands, there's two kinds of nursing roles. So there's the physical health type of nurse for chronic conditions, but then there's the mental health nurse as well, who does the, more counseling, et cetera, for people with mental health concerns. But the real secret sauce in the Netherlands, which is something I didn't see quite to the same degree in any other country, was this healthcare worker called a practice assistant. So the practice assistant, and I think in Dutch, it's kind of more translated to doctor assistant or doctor assist, but it's not actually a physician assistant. So just to be very clear, it's probably something between a medical office assistant and like an RPN or RN role. It's nothing like what we have in Canada. And what they do, they are actually trained for 3 years. You can do it out of high school. And they describe themselves as like the right hand of the doctor. They do very sophisticated phone-based triage. Again, this triage algorithms are all based on the Dutch College of GPs work with other organizations, all publicly available on the website. And they have this 3-year training specifically on primary care triage and how to communicate with patients. And so all the common complaints that might come through, they're able to talk to patients to support them to self-resolve, like to resolve the issue completely if needed, or to decide, okay, no, this is something that needs to come in today. No, it's something that can come in a week. Oh, this is something that a nurse could see. No, it's a doctor who need to see them. Or maybe me as a practice assistant, I can see them. Because they also do consultations within the office. They do things like pap tests, ear syringing, wound care. So they can do a lot of things themselves in the office setting. And so important context there is that in the Netherlands, it is actually the GPs are gatekeepers to the emergency room.
Oh,
And so you can't actually go to the emerge without a referral from your GP. So you can imagine that you have to provide very timely care.
wait. So you're gonna be like bleeding out the side of your head and you have to see your GP
No.
first, or you know what I mean?
So if you're having a heart attack or like
Yeah.
trouble breathing, it's a trauma, like, yes, then you would be going in an
Because you'd be
ambulance to the
calling
emerge.
911, the 911 equivalent.
Yeah,
Okay. Okay.
exactly. But if you, I don't know, fell down and you thought you might broken something, you'd see the GP first. If you have a fever, if you bad tummy pain, bad vaginal bleeding, like all those things, you would see the GP first. And when I say see, it's actually the front door is this virtual triage system. And it's there in the day in the GP office. And then after hours, the GPs actually have these cooperatives that they work in, hundreds of GPs together serving a whole region. And I mean, really organized after hours care. Again, these practice assistants are there answering phone calls. One GP might supervise like 8 to 10 practice assistants who are answering calls, working off these triage algorithms that they've been trained on that are also embedded within their electronic medical record. And the practice assistants will, figure out what they think has to happen. They can consult the GP if needed. And the GP is there to see them in person. But interestingly, the GP also can go and see a patient in their home because it's very standard for every GP to have like an hour in their clinic day for home visits. And in the after hours center, there's actually a car and driver available to GPs for GPs to use to go to do home visits for people who can't come in but are sick. So a very human-centered healthcare system, very different from what we have, where so much of the time our most vulnerable patients are just left to fend for themselves in a way that deteriorates their health. I think about people who are so ill and homebound, but then come in an ambulance and are waiting on a stretcher for a long time to be seen. When what would be so much better is if we were able to actually assess them at home. And so, yeah, they have, anyway, this very sophisticated model of ensuring access that is really predicated on virtual triage by these practice assistants and also these other components that they've integrated into the models, both during the day and after hours.
A really interesting theme that I'm hearing in both of the countries we've explored so far is like you say, both of them are very like patient experience centered. They're designed so that patients have a good experience. And one of the ways, the clear design of that is to also make sure that the clinicians are having at least a supported experience, right? So paid enough of them, enough of a team. So it's not like one doc doing all this care by themselves, right? Like, so, because sometimes it feels like it's at odds, or it can be sort of said it like, oh, in order to be patient centered, clinicians have to sacrifice or something. But it can actually both can be true. And like, of course,
Mm-hmm.
centering the people who are needing the care. uh, I mean, otherwise you have sort of completely lost the purpose of providing care, right? Like, yes, the reason that we're all here is to provide care to the patients. And the way that you provide care to the patients is by well supporting and coordinating and organizing the people who are providing that care.
Yeah, I mean, I will say though, Joan, is I think a lot of this though in the Netherlands, like where I spent probably the most time was the Netherlands. I think that it was the GP self-organizing.
Wow, that's
So
cool.
like,
Okay.
right, like they have this tradition of family medicine, of primary care being a GP. And this Dutch College of GPs goes back decades. Like it's a decades old organization. It's member based. So the GPs pay a membership fee to belong to it. And so they have decided like that is important that they're going to create their own guidelines. They, as a college, I don't know the evolution of how they developed the primary care triage pieces, but they clearly have developed tools that GPs around the country feel comfortable with and are also integrated then into the electronic medical record. They recently, as a Dutch college, also in the last few years, have a patient-facing part of their website, which actually has like lots of really great patient education on common conditions that can be self-managed. And the GPs there anecdotally told me, oh yeah, since this website, like I hardly ever see like allergic rhinitis or whatever, like because people know what to do. So there's a self-organization. And then the after hours definitely was a self-organization. So it, the tradition in the Netherlands is that, and the contracts specify that Dutch doctors are responsible for their patients 24/7. And it used to be like 20, 30 years ago that the doctors would just be on call for their own practice 24/7.
Yeah.
And you can imagine that was like hard.
That sounds not fun.
Yeah. And so they shifted
Uh,
into this model. So these amazing after hours care centers that I visited more than one. And I had a colleague who went over to the Netherlands with me and she visited a couple of different ones too. And they're all pretty standard. They're actually all GP cooperatives. So the GPs co-own and manage this. Like I think they have like a board and like an executive and all the things, right? And they own or rent the space and they hire the staff and they're accountable. But like they have made this system that works for their patients, but also works for them. So I do want to put that out there that I don't think it's like somebody created the
the
system. I
government didn't
think the
dream it up. Yes.
GPs
Yes.
self-organized in many cases to make it what it is.
And in some ways, doesn't that sort of even just logically make more sense? And this is, again, this, I'm not ever saying it like against, but like, wouldn't it make sense that the people who are delivering the work, they're given the parameters of the job, but they're the ones
Mm,
delivering the work. They're with the patients. So them feeling empowered and I guess not being stopped in some way by the government, but like they're like,
mhm,
oh, okay, so these are the parameters. So how do we do this best with each other? And that it's like I
mhm.
think that's so inspiring.
Yeah,
Yeah.
I think that there is that attitude there, and I also think part of that is there is sort of this expectation to serve a certain roster of patients, and so they have had to figure out how to be efficient to provide timely access to a large group. And so the practices I visited, both in the Netherlands and Denmark, and we can talk about Spain too, which is a different model, but they there is this sort of concept I've started to talk about more called demand management, where you have to figure out like who needs to be seen when and by whom.
Yes.
And we do a terrible job of that in Canada.
Yes.
And, you can do it with a person like a practice assistant. You can do it with, you know, decision support or, IT and maybe AI or whatever, or a combination of the two. But you do have to do it, especially if you want to provide timely care to a larger roster of patients. And so I think that's something that they've kind of been forced to address. And I will say one of the things I also noticed in all three countries is what the doctors don't do. So none of the doctors in any of the countries do cancer screening.
Ah,
That is other people's responsibilities. So in all the countries, colorectal and breast cancer screening is run by a public agency. The doctors are not involved. The family doctors, the GPs are not
how
involved.
about like immunizations? Is that maybe varies, but
It varies by
yeah.
country. In the Netherlands, for example, there's actually like a different type of clinic that does well babies and immunizations. The GPs see kids, but they don't see them for well checks.
Yeah.
In the Netherlands, they don't do any well checks.
Yeah.
That's just like not a thing.
Ugh.
They do pap tests, but it's the practice assistants, as I mentioned, that do pap tests. And in Spain, actually, HPV self-sampling is very common. So they really, I think, taken work away from GPs. So the preventive care, the stable chronic condition stuff, I think is actually physicians delegating that to other people, the nurses. But at the same time, the doctors in the Netherlands, they do house calls, they do end of life care. Like, so there's things that like a lot of family doctors in Canada don't do. Some of course, our colleagues are doing those things, but not all.
And sometimes it's about interest, but also it's about capacity. It's about the fact that if your
Capacity,
job
yeah,
is actually
absolutely.
this large, then it's like, well, which pieces are easiest to chop off? And like,
And it's in
right?
fairness, it's also about geography, and so they have
Totally.
actually also kind of a requirement there that your doctor is supposed to be within 15 minutes of driving from where
Wow.
you are.
Yeah.
Yeah, so it's partly to facilitate that that the doctors are able to do home visits.
Mm. Okay, we're running low on time. I'm just aware. But I want to hear at least like a few.
What a great conversation, right, Jen? We could go on
I'm like, I
forever, and
have
I didn't even
so
talk
many.
about
I
Spain
know.
yet. Look at
Okay.
that.
Well, I would love to hear at least like a couple nuggets from Spain. And I also would really love to know what the like disability form situation is in all these countries, because I don't know, that's it's one of my things of like, does every country do it this way? So those are my last two questions. Obviously, those could be
Okay.
big,
I
but
don't unfortunately have a great answer on the
okay.
disability forms. I will say, like in the Netherlands, I did hear that as a one of the doctors told me that they, as a profession, like I guess at some point a few years ago, just decided that they are not going to write sick notes. And so like they do not write sick notes.
Para, I don't know if you remember when we were in a room where I proposed
I know.
that. That's
But
all
like
I
they all
needed to
decided, like as
know.
a
I That's what we
national
have
body
to
of family
do.
doctors, GPs, like we
Wait,
are just not
was
doing
that
this.
Denmark? I
That was the
Oh, that's
Netherlands. Yeah.
Netherlands. Netherlands.
I
I
knew
need to
it.
look into this. I'm leading a
Yeah.
movement. I don't know if it'll happen, but that's just good information to know.
It is. It is. I do think that GPs look after fewer social issues in those countries. Just the sense I got from shadowing, I'm not sure. Some of it is that they think there are different types of social infrastructure to support people that are missing in our society and that then fall on the GP. That's the kind of sense I got. Importantly, I also think like sometimes in our society we have certain issues that they might like we have a lot of ethnic diversity, as I mentioned in Canada, but we also have like an opioid crisis, and they don't have the same level of opioid crisis that we do, and so I think there's certain social complexities that we have that are not present there. But then to your, with the nuggets in Spain, let me just say that it's a very different model than in the Netherlands and the UK, in the Netherlands and Denmark, because they are for the most part, government run primary care centers. Not all, but they're all kind of government commissioned. So they have these primary care centers that are geographically based, that are teams and really integrate not just clinical care in the clinic, but actually wider community based care. And in this model, actually, the GPs, along with all of the other team members, are all employees. So a very different kind of model. And it's this geographic model, as I mentioned, where anybody within the geography has the right to care at the center. And you can just walk in to go get that care. You will never be turned away. But it's not just for people who walk in. Let's say, you are homebound. The center is still responsible for supporting you. They support the people in nursing homes. And what was really I think unique about the Spain system is really that integration of the community health prevention and promotion type of aspects with primary care. So, in the centers, it would be pretty standard for like the larger centers or centers to band together to do this to, for example, understand community needs through doing quantitative type of survey and understanding like what are the changes in the demographics of the population and the disease prevalence, etc. And also qualitative stuff, focus groups to understand what is it that people care about most, what are they talking about, what are the kinds of things they want education with or services that they might want. And then, the people in the clinic, they do go out into the community to so it's actually family doctors and pediatricians who work together in these centers together with nurses. Family doctors and nurses are kind of the core dyad. Family doctors look after people 15 and over, whereas pediatricians look after people under 15. But let's say, the family doctor or the nurse, they might go to sometimes, or the pediatrician might go to the school, the family doctor or nurse might go to like a day program, to an adult day program to give a talk or something like that. So there's just this community integration and health promotional aspect of the centers that is very much connected also to the delivery of primary care. And, the doctor, what they do in the clinic is not unlike what you and I would do, except again, the chronic condition management very much delegated to the nurse, not so much the prevention focus. They're generally seeing people who are sick, have more complex chronic conditions or mental health issues.
And would that one be, are they, are most people still attached? Like part of, I think what can be tricky about our system is like, you think you have your one, like my patients are like, I only want to see you, Dr. Chan,
Mm.
you know?
Yeah, so every doctor and every nurse
Mm.
has a roster. So the
Oh,
roster says there are about
interesting.
1,400. So every patient, I should say, has a named doctor and a named nurse.
And they work as a little
Usually in
duo.
most centers, it's the same people, like the doctor and nurse care for the same group,
Yeah.
but in some centers, it may be different. And the patient usually has some agency over choosing, but there is some managerial kind of oversight so that it's a fair distribution. So let's say you're very popular, Joan, and I'm not, and everybody wants to be your patient. So then the manager might be like, no, you can't be Joan's patient anymore.
Gotcha.
You have to be Tara's patient now.
Even having
So,
someone else to help manage that sounds lovely
mhm,
versus, everyone just applying and you're like, oh gosh, what am I going to do?
But they never turn anyone away from the
Right.
center.
Right. That's
Yeah.
find someone. And I guess are nurse practitioners a role in any of these countries? Like or do the nurses here prescribe and order tests?
Yeah, it's a good question. I didn't see nurse practitioners or advanced practice nurses in the settings that I visited and didn't hear about them to the degree that I hear we would have them integrated here. There is instead, like, I think, a more focus on nursing. And I think there may be some advanced practice nurses, but there's just not a lot of them. But the RN role is very strong. And there is a lot of, like I said, this delegation. So the nurses, like, for example, in the Netherlands, they would potentially, they don't prescribe, but they might like put it into the electronic medical record somewhere, like in a way where the doctor just reviews it and then like authorizes it. So it's a very quick kind of authorization and review by the doctor because the nurse has, for the most part, based on these algorithms and guidelines, chosen the thing that the patient probably needs.
Oh, that's so interesting. Oh wait, I did think of another one. Okay, I think how do the doctors in these different countries feel about their inboxes? I don't know if you asked them
Oh
that.
yeah, that didn't seem like as big a thing there
Yeah.
either. I did ask about it, but it just seemed like their whole information management system was just more efficient.
Yeah.
I mean, certainly I did look and observe like the referrals. So I mentioned in Denmark and the Netherlands, it seemed to be a pretty central referral portal for most referrals, diagnostics or specialists. Part of the reason I think is that I think most specialists have to be affiliated with a hospital. So they're sort of like you just refer to the hospital and there's sort of like a standard form and then they take care of the triage of the referrals and the booking and all of that. And so there isn't that headache around referrals in any of the countries that I experienced anything like ours. The other thing that I should say that is wonderful there is the patients have access to their health records online. And and I said I visited Spain. I should actually be more specific. I visited the province of Catalonia, the region of Catalonia. And just like in Canada, the
Gotcha.
healthcare system is decentralized. So every autonomous region does things a little differently. But in Catalonia, like they've had a patient held record and an app for people since 2009.
Wow.
Yeah,
It's
and like they
possible.
can look up all the things. They can look up their medications, their lab tests, like what waiting lists they're on. They can do e-consults with physicians. So in Denmark and in Spain, e-consults are very routine. And in the Netherlands, it's growing, but it's not as routine in those two other countries. So that was an interesting one where I could see in the Netherlands it was a new thing. And so some practices had figured out, I think, how to like make it efficient but they were still kind of trying to think through like, how does it fit in my day, you know? Um, but yeah, it was integrated though into the electronic system in a way that was very efficient, it seemed to me.
Yeah. And you can see how that, because like I know, oftentimes And I relate to it in the past, certainly. Like, if I have to sign into a different portal with a different password, and so you just don't, even if it's really great, you like don't even try because you're like, I
Yeah.
can't, my brain's full, right? So if it's
Yeah.
all seamlessly
Yeah.
integrated, it just like lowers that barrier to doing the thing.
Yeah, and I
Yeah.
think the other thing I noticed too, I think one of our frustrations, Joan, is like we go onto our electronic medical record, and now we didn't used to get any stuff from hospitals in a timely way, and now we get way too much stuff, and it's like overwhelming
Deluge.
and terrible, actually.
Yeah.
That was actually one thing I noticed notably different from when I left a year ago is I get so many more HRM
HRM has
messages for
come
people in
online
the
in
know. Yeah.
Toronto,
So like
and
all these reports from hospitals of like every ECG that a patient might
yeah,
have had in a hospital. Like, I do not need to know all of those
you don't need
things.
to know every cat blood sugar that they have
And
done in the
so, yeah.
hospital.
So
No.
that's not, that kind of thing is not there. But instead, like within the electronic medical system, you can kind of like tab to looking
That's
at
cool.
people's hospital record,
Right.
right? So it's very easily accessible. It doesn't require a separate login, but it's also not taking up all this space in your record, in your message box in a way that's unhelpful.
That's beautiful. Okay, so then having gone all these beautiful places, my two questions are, so one is, what did you feel either inspired, you've already done it, or you're like, oh, that is a good idea. And I can see how I could do a mini version of it in my own practice. And um, which of these ideas do you think could be some of the juiciest to propose to, the next time you're chatting with a politician or if you're on a committee to design such things, for example, like which of these do you think would be like, ooh, this one that's top of my wish list of like, how, and maybe seeing a bit of a path forward of how we could doing it, not solving the whole thing. No one's going to solve the whole thing immediately, obviously, but big system,
Yeah.
small system.
I think so I'll start with the big system. Um, I think there's quite a lot that we can learn. I think one is moving cancer screening, especially so colorectal and breast cancer screening out of primary care and also reducing, the preventive focus of primary care and trying to get other fund public health or other entities to do health promotion and prevention. I would love to see us train a workforce like a practice assistant. I feel like that would go a long way. We have a huge doctor shortage, a huge nursing shortage. It takes a while to train those professionals. These are people who come 3 years out of, like, it's 3 years training after high school. They're trained in, and like this idea that they're trained in primary care triage. So I would love to see us borrow and modify the primary care triage algorithms and support training up a workforce that's like an upskilled medical office assistant type of role, where it's a doctor's right hand and they can do so many of the things that doctors don't necessarily need to do, that allow then doctors to do other work and be more efficient with their own time and care for more people, which is really what we need. Big system stuff. I don't have a how we should do this, but it is kind of crazy to me that like an integrated record and the
Yeah.
patient held record is like not here right now. And, shame on us that other countries are so far ahead of us in this space, despite us apparently having it on our work plan for decades.
For decades. Yeah. And okay, do none of the other provinces have this? Does Alberta a little bit have
So
this?
yeah, no, so
Yeah.
some provinces are ahead of us
Okay.
for sure.
Yeah.
So in Alberta, they have a single they have this, all hospitals are on the same electronic medical record. And my understanding is patients can more easily then access those pieces. Primary care is not integrated into that, but at least it's a step. It's more than what we have here in Ontario. So you're right that it is better in other provinces, but we have a ways to go. Yeah, so those are some of, like, there's a lot of
Yes.
ideas, I think, from a big system level, but those are a few that kind of stand out. And I guess one that is at a cross, I think, between a big system and a small system is this idea of supporting patients to self-manage. I love the patient-facing website that's based on Dutch guidelines that were put out by that Dutch guideline body. And, I feel like that's something that family doctors should be able to do. Not each family doctor on
No,
their own,
we're
though.
not all writing our own blog.
So
No, that's
just
so
to be
silly.
clear,
Yeah, it's like
but I
point
but
to
I
the
think that
resources.
that
Yeah.
is something that we should be able to band together to do to support our patients. It does drive me a bit crazy that, patients who have conjunctivitis, we're encouraging them to go see a pharmacist when actually most conjunctivitis is viral and they can just manage it on their own. And then even if they needed bacterial like something, they can eye drops or whatever, they can go to a pharmacy and buy it over the counter. But like they don't need to see a health professional. And we can teach them what are their warning signs in order to go and do that. But I do feel like that's one that should be really doable and within our own control. Yeah, I mean, and then you asked like, what is something that would I do like within our, my own clinic maybe? And that is a really hard, it is a harder thing. I mean, maybe it relates to trying to figure out again, like how I can spend less time on the prevention and more time delegating some of those pieces. I work in a large clinic though with a lot of other doctors and policies and stuff. So, that's something that we would have to agree on together. Some of the things we would have to agree on together, but I think could be attainable.
I can share some of the ones that I'm doing that I'm like, oh, that's kind of
Yeah.
cool that's Danish or whatever. Or I forget, no, I think it was Netherlands, where the nurse sees the 3 out of the 4 diabetes visits and I
Yeah,
just
yeah,
see the one.
yeah.
I don't have it as firm as that, but I'm like, ooh, maybe I should just be like, I'm doing it. Was it the Dutch way? I think it was the Dutch way.
Yeah.
Um, which means that I'm giving up my KO3Os. So that's
And that's an
where
unfortunate like incentive. Like it is a
backwards incentive.
backwards
It
incentive.
is, yeah. So sometimes I still do them as joint, and then I do my
Mhm.
part, and then I get the KO3O. But I've just
But
had to
maybe it's the
decide.
hypertension or the asthma or
Yes.
the
Oh,
cardio, like,
lots of those go because like so I am in the privileged position to be in a family health team. So
right.
there we
Me
have a
too.
PCNC, primary care nurse clinician, and so she's trained. So so only if like someone's come through my door and I'm like, wow, your blood pressure is high, so then maybe I like take it over. But I just try and really quickly be like, next time, see Christine, and then she sends me the message, and so like there's
That's
some pieces like
great.
that where I'm like, go ahead, go ahead. Yes, is there a way that it's unpaid work? Yes, is there a way? La 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 la. But like in this role, I have to triage how I'm spending my time. And so
Yeah.
those pieces someone else can deal with. And just the whole concept of demand management, that's something that I'm still evolving, but like just trying to innovate for myself personally, what feels good. So like that
Hmm.
piece is a huge one, like delegation. I've privately hired a nurse practitioner to like share my practice with me. So I'm like investing in this just for myself and my
Wow.
sanity. And it's so good. Like the dyad concept, like, and like the sharing with someone else. I just wish that we could at least explore that as being one of the main models because like there's actually so many benefits to it, in my opinion, of like even the
Yeah, I
quality of
will say this
care.
practice I visited in the Netherlands, it was actually it's 4 full-time practices, but shared by 8 people, and each was a dyad. And they were actually all men-women pairs.
Cool. That would be nice for
Yeah.
patient preference potentially too,
Yeah.
right?
Anyway, it was interesting, and they all like literally, I think, worked like 2.5 days in the clinic. They were academic, so they also had other roles.
Yeah.
But yeah.
That shared thing. That's so good. And
Hmm.
then my last like demand management thing that I do is that I have a patient portal that I pay for. And
Mm.
technically, I'm a part of the Secure Messenger pilot. So that means I get up to $54 a month for doing all of that care. Which I just have to not think about. But like on it, like I started that before the pandemic because there was another pilot where it was paid slightly
Oh.
better. And during the pandemic, game changer, people messaging me their concerns, their questions. I
Hmm.
don't want to see them, and I didn't want to see them on Zoom either. I mean,
Mm.
if a patient's listening, oh, of
Hmm.
course I want to see you, but like there's too many.
Yeah.
The demand's too high. But actually, a lot of them are just like, I'm nervous, or like, can you give me resources? Like recent, someone's like, hey, I think I have this condition. Can you just share resources with me? And like, I'm
Yeah.
so glad that they asked that, and then I could happily give that to them. A lot of the times it's like, do I need to come in? And I like ask a few questions and I'm like, maybe you don't. And like down the road, perhaps I'll have someone with me. Maybe I'll, cross train my nurse practitioner or someone so I'm not doing it on my own, but it's actually not too burdensome at this point. And it's just a way that I think of it as my access lever. Because so if people
Yeah,
cannot get in, they can
absolutely.
at least message me. And I'll say to Em, like, I'm always constantly marketing and I'm like, just so you know, next time maybe you can just message me. Like I was like trying to keep people away. So this is something I think the demand management concept, how cool would it be? And it's so empowering. That's the other message I'm going to take is like what like and I almost have like a pang in my heart for like how no one's fallen individually, but like we don't have this like collective family medicine culture per se. And maybe we're just too big and maybe like each pocket's probably different and some communities have it stronger than others. But like this
Yeah.
sense of like, and it's not I have none, like we have a call group, etc. But there's something, it sounds like it's sort of baked into the profession of like, we're gonna like look at these problems together and come up solutions together instead of like each little person or each community having to like totally figure it out,
It
you
does,
know?
it did seem like that to me, and that particularly there was a lot of family doctor leadership who were able to spend time to do this. Like, I think they
Yeah.
actually do have more family doctor, potentially PhDs and academics too, who like probably support some of that work related to the guidelines and things like that. So, because do need people who have some time that is not clinical to be able to lead those kinds of initiatives, right? That then can support like a whole bunch of people to have a better life.
Mm. Well, thank you so much, Tara. This has been an invigorating conversation. I was like, I'm gonna have a million questions for you. And I did. And I'm like, yes.
Well, it's my
No.
pleasure. And
Yes.
before we leave, I should probably mention, John, that the other thing I did on my
Yes,
sabbatical
please.
was start my own
Woo,
podcast.
so
Yay,
fun.
inspired by you. And thank you, Joan, for your advice as I was starting up here. So it's called Primary Focus. And if you are interested in learning, more about innovations in primary care around the world and also in Canada and, how we can try and build a better healthcare system that works for everyone. I urge you to tune in, see if you like it. I will say, I did do some podcast recording on some of my trips, and so we have a few documentary style episodes from my trips to the Netherlands, which take you behind the scenes and take you into the clinic and take you to the after hours center and all these things. So yeah, I hope you enjoy it.
I am absolutely listening. I already said, like, when I saw that you launched it on LinkedIn, I like followed it, but especially those
Yay.
documentary ones, I want to hear the Danish and Dutch and Spanish voices talking about. I'd love it's
Yeah,
so
it's fun.
fun.
It's fun.
That's so cool. Um, is there anywhere else that you want to point people? Oh, did you also want people to fill out the survey?
Yeah. So, as I mentioned, we did this big survey back in 2022 of people in Canada to understand their experiences of primary care and what they wanted to see in a better system. And that's how we came up with that number of more than 6.5 million people without care. We think that's probably changed. It's important, I think, for us to have really good data about where people are with primary care across the country. So we've launched another survey, this time in partnership with the Canadian Medical Association. In that survey, you can go to ourcare.ca and you'll see the survey link right at the top. It's open until July 9th. It should only take 10 to 15 minutes to complete. And please do share it with others. We're really hoping for a very large response rate to help us understand what primary care access is like right now, but also other parts of what we call the Our Care standard. So people told us what it is they want to see in a better system in the public.
Yeah. Okay. I wrote it down. I can email it to my patients, right? Yeah. I
Yeah,
have like a
thank
mass
you.
mass
Yes, share
email
it to
thingy.
your patient newsletter.
Yes. Yeah. Because like represent and then be like, forward this to your friends. Wonderful. All right. Well, the last question I always invite the guests to ask is picturing those listening who are folks that I mean, they have some amount of at least curiosity or hope that things could change to where their experience of delivering healthcare as well as receiving healthcare feels more human. Um, and that's why they're listening and they hear all these different ideas of ways that maybe they can, be empowered to make change themselves. But it's hard. So do you have any words of either like encouragement or advice that you would want to offer them from your perspective?
Wow, that's a hard one, but I guess I'll say a couple things. So one, I think you kind of alluded to this earlier, Joan, is that sometimes we think of taking care of ourselves and taking care of our patients as being things that are intention. And I think that it's important for us to think about how we can put an and between those things, that I am taking care of my patients and taking care of myself, fulfilling, my purpose. And my purpose is taking care of patients in a way that feels good to me, right? And so I think that's like a general piece that I would put out there for people. And I think, as you pointed out, in some of these countries, I did witness that people were able to attain that. But I feel like I've also witnessed that in Canada. And some of that, I think what I've also come to feel is it relates to us putting limits. If we feel that it is encroaching on our wellness, I worry sometimes about people being, so, trying to do all of the things for their patients to the point where it really takes a detrimental toll on them and then they quit medicine,
Oh, what a
which is
tragedy,
actually
right?
not good for any patient.
No.
And so, what can you do to support yourself to still enjoy the work? To do the and I guess it's partly what we also talked about is this demand management. How do we triage the things and do the things that we know are really important and maybe leave some of the other things behind? And we can't take on all the deficiencies of the healthcare system. We can't counsel people on every guideline based preventive care maneuver that's out there. It's just not actually realistic. But we can help people who have serious illness and, we can prioritize the things that we think matter most, but also make sure we do it hopefully in a way that enables us to take a break when we need it.
You're singing my
It's not
song.
helping anyone if we get burned out and leave.
Yes. And my additional thing is look into sabbaticals. I know I'm
Yeah.
going to. And, like I've said on a recent podcast I put out, it's like, so like, sabbatical could be like you did before. I'm like, ooh, 2 to 3 months. That's fun. I've done 1 month and that was like, woo, so fun. As well as mat leaves that
Hmm.
are different than sabbaticals. But even like, what if, out of the office 1 day per week or, like kind of micro, but also
Hmm.
I'm thinking about
I think you and I
macro.
actually talked about this a couple of years ago. We both did this one fall, took a day off to go hiking.
Yes. Come on. So that like for
Yeah.
you, so not take
So it
off.
can be so it can be micro,
Yes.
to your
And
point.
those are so because it can feel like, oh, I can't take any vacation because the work's so much. It's like, what if the work's always going to be way too much? Because of the
Hmm.
demand management, when you have, 1.6 times less doctors, maybe
It's hard.
the math is
Yeah, yeah,
not in our
yeah,
favor.
yeah.
So we just got to go ahead and just preserve ourselves in the storm, you know? Lovely. Well, thank you for all of your time and expertise. And I just love knowing that you are in the same primary care healthcare system as me and doing this beautiful
Oh,
work
that's nice.
to like enact change that's like human centered, which includes the humans receiving and the humans offering the care. So thank you for everything you're doing. It's so wonderful.
Thanks, Joan. Thanks for having me today.
Sure.
It's been a lot of fun.
All right. And everyone else, I hope you have a great week. We'll talk to you next time. I would love to take this work deeper with you. Visit joanchanmd.com today and discover my growing menu of options for restorative medical education to suit your learning needs. I offer one-on-one coaching, customized workshops, and self-study courses that allow you to connect not only with my work on a deeper level, but also with other healthcare humans just like you. So if you want to start humanizing your work and healthcare to a deeper level and do it in community with others, please visit joanchanmd.com and find those options and what fits you and your life today.